Welcome everyone to Confidence Dental Podcast. The purpose of this podcast is to enlighten all our audience regarding the CBCT. What the CBCT can do in terms of elevating your practice, how it can help your diagnosis and treatment planning, and also the benefits of CBCT for your patient. To enlighten us about all these facts, today we have our esteemed guest speaker, Dr. Rakesh with us. He is a professor in Oral Medicine and Radiology at M.S.RUAS University of Applied Sciences. He is a researcher, speaker, academician and practitioner who has got more than 100 publications to his credit. So we welcome Dr. Rakesh for the show. Thank you for coming, Dr. Rakesh.
Thank you for welcoming me here, sir, and thank you very much for such a wonderful words about me. Hope so we have this discussion which would be helpful for all the people who are listening to this podcast.
Dr. Rakesh, we have a lot of young dentists, dental students and practitioners who are just starting off their practice. So let's begin with the basics. What exactly is a CBCT and how is this CBCT different from a conventional OPG?
Yes, sir, that's a good question to start. Like in case we see as a student, we used to be we used to make IOPR radiographs, that is intraoral periapical radiographs, which usually used to cover only up to 3 to 4 teeth. Then came the introduction of panoramic radiograph was there from much long time into the history of dentistry. But as such, in relation to the clinic or as an undergraduate program or in relation to the private practice to a certain segment, when we wanted to view the whole of maxilla as well as to the mandible, where viewing all the teeth, assessment of all the teeth was very, very essential, has become very essential to the part of treatment as well. In those situations, we have something called as an OPG, or we also call it as a panoramic radiograph, which forms a stable sort of a radiographic image, which helps us in assessing both the maxilla and mandible at the same time. But at the end of the day, the panoramic radiograph or the OPG is a two-dimensional image. So we have lot amount of overlapping things which is happening. Usually the structures whichever are there, like be it your nose, or be it your lips, or be it your spine, all these things are getting overlapped onto a radiograph where we tend to get one single image of it. But that in relation to a CBCT, it is a three-dimensional recreation of this two-dimensional things. So usually we have structures which can be layered something like a pages in a book. So that is a major advantage in relation to the CBCT as in comparison to the panoramic radiograph or an OPG, what we call. At the same time, we also have certain amount of things called as a magnification in relation to a panoramic radiograph, which would be totally negated in relation to a CBCT. So mean to say what? We tend to have 1:1 ratio of the measurement and the size in relation to a CBCT as in comparison to a panoramic radiograph. That is OPG.
Thank you very much, sir. So you mean to say that orthopantomogram is a 2D image, whereas CBCT is a 3D image, and in CBCT there are no overlaps and there are different layers to it which you can peel and see the depth which is missing in OPG, and also OPG tends to have magnification.
Yes.
So if it tells it's 108% or 113%, the actual image is magnified in the image, so you can't take it as it is. So we have to apply the error coefficient, so which is missing in CBCT. Dr. Rakesh, now that we know CBCT is a layered kind of imaging which is 3D, so obviously it will have some benefits over the conventional OPG and IOPR. So what exactly are the indications where we can utilize the services of a CBCT?
See, the indications usually stay basically as panoramic radiograph, but whenever we want in-depth analysis like assessment of number of canals, what to see in a canal, or disimpaction, assessment of the inferior alar nerve canal in relation to the periapex of third molars or the molars, fracture assessment, fracture be it dental or alveolar, dento-alveolar component, assessment of temporomandibular condyles, then assessment of maxillary sinusitis, because that also plays an essential role. Then assessment of for the intermaxillary growth, or to the assessment of the maxillary size, as well as to the occlusion, and for the assessment of prosthodontic rehabilitation also.
So, in a sense, this adds a depth component to the radiographic image.
Yeah,
What we used to have.
that's you got me correct.
Yes.
That's what I wanted to say. It actually acts to the depth in relation to the panoramic radiograph. It gives us more amount of information, helps us in being more confident in planning our treatment.
Can we invert the image in the sense, in the panoramic radiograph, whenever I am performing a periodontal surgery, I see only from the buccal point of view. Suppose we want to invert it and see how it appears in from a palatal point of view or an occlusal point of view. Can we do that in a CBCT?
Yes, sir. All these digital images have got the capabilities, and because we are acquiring the images in all the three planes, that is sagittal, occipital, and coronal portions, we can always change. That is the reason basically we call it as a three-dimensional image, because we are acquiring in all the three planes. So each image can be changed, can be shifted, whether you want to see from buccal, palatal, lingual, occlusal, or from the apical, or to any other surface, whichever angulated way we want to see. But that would not happen in relation to a panoramic radiograph.
Dr. Rakesh, most of our dentists are familiar with the use of CBCT with respect to implant dentistry. Many of them are utilizing even for guided implant surgeries. So in that sense, most of them are familiar with it. But I want you to throw some light on other aspects of dentistry, other specialties, and what kind of cases CBCT can be of more help to solve the challenges faced by our dentists.
Yes, sir. Now, as you say, it's primarily been used for implant per se, most. But in case if I want to answer this question, I would like to go department-wise as in relation to the dentistry. Starting with endo, we can see for the number of, the same way I had answered before, we can see for the number of canals, the place where it is getting where to see. And in relation to the assessment of my calcified canals, in relation to the prosto for the assessment of my root surface or to the occlusal surface, in relation to the surgery, again, we can go for the disimpactions, fracture assessment, in relation to the rehabilitation as in relation to the prosto, where most of the people nowadays are going for the rehabilitation of a missed structure, especially post-COVID, where we tend to see this osteomyelitis, where rehabilitation of structures like eyes, maxilla has been there. CBCT can play a major role in understanding and assessment of it. As in relation to the pediatric dentistry, I would not suggest for all the people who would go for CBCT. We would always have a restriction amount of use of CBCT in pedo, but sometimes whenever we weigh the usage of the radiology for the diagnosis in comparison to its side effects, we would always suggest. Maybe because of pediatric tumors have become of late, which has been increasing more. And the identification has also become more because the parents are very specific or very worried about their kids. In those situations, we can do the same way the cyst tumors, those things can also be assessed in relation to your surgery. So which helps us in assessing what is the size, what is the volume, what is the shape of it. For the assessment of the bone, as in relation to like if you want to see for any osteomalacia, osteopenia. So mandible actually plays a major role as in comparison to the other long bones, which can always be identified, which can also be helpful in treating the patients.
Okay. Oh, Dr. Rakesh, wonderful. You basically covered almost all the departments of dentistry. So CBCT can be used in pediatric patients in certain cases, for cysts, tumors, to assess the size, the bone quality. Vitamin D deficiency is a major problem, especially post-COVID, and disimpactions, to identify the root fractures, the number of canals. You pretty much covered it all. I would like to ask one more thing about this. What about airway restriction or sleep apnea? Because that's a silent killer that's on the prowl, and many people are suffering from that even without knowing. So how is dentistry connected to it, and how CBCT can solve this problem?
Yes, sir. I actually missed that point in the previous question. Sleep apnea has become, which is catching up now. It's called as a silent killer as well. The CBCT actually majorly plays a role in assessing, identifying pre-therapy as well as to the post-therapy. It actually increases the size whenever you are doing post-therapy. We can see that upper airway space increases. Not only in relation to this, as in relation to the ENT also, the mid-ear infection, middle ear infection, or to the assessment of any components associated with ear, that can also be identified with the CBCT.
Dr. Rakesh, it's wonderful to know that CBCT can not only help in dentistry but also airway analysis, and even in ENT solutions like middle ear infections or the defects in the middle ear. I want our audience to know, and we would like to understand, there is something called as field of view, or FOVs in a CBCT, where it covers a particular amount of area in imaging of the face. So what FOV would you recommend for a routine dental clinic? Can you show some light on that?
Yes, sir. And now, in relation to the panoramic radiograph, like how you've been discussing panoramic and OPGs, we don't have a portion which has been segmented. Like in relation to the CBCT, in comparison to the CT again, one of the major advantage of CBCT is that we can restrict the amount of view how much I want. So this would help us in decreasing the amount of radiation to the patient per se. It also helps us in identifying and localizing only to a certain fragment which is required. So that portion is called as a field of view. The field of view can range from 4 by 4 centimeters, which goes to the upper size like 16 to 30 centimeters or 13 by 17.5. Do we require the larger FOV in a clinical practice? I probably think that 10 by 10 centimeters would probably cover all the aspects in relation to a private practice. But whenever you want to do certain amount of research aspects, which probably would come more into the academical part, so I would suggest there. As in relation to a private practice, I would more be very happy with an FOV of 10 by 10.
So in a nutshell, 10 by 10 centimeter FOV is sufficient for a private dental clinic who are doing the routine dental procedures. Is this 10 by 10 sufficient even to cover the TMJ or the condyle?
Yes, sir. This 10 by 10, most of the things covers maxilla and mandible, both the things. Yeah, when there are certain indications when you want to visualize the temporomandibular joint, in those situations we can actually change the position of the patient, where the person can be got into the field of view, where the visualization of one side of the condyle can be captured. So in case, but all those, the incidence of these things would be less. In case if you want to visualize both of them together, you can always refer to an higher center which has got a larger FOV. But yes, in relation to a private practice, if you change a bit of the position of the patient, you have a well-trained technician or the doctor, yeah, we can acquire. That is possible.
Doctor, during the previous question, you mentioned about CT scan and CBCT. So I would like to know what is the main difference between CBCT and a conventional CT.
In relation to CT, we tend to acquire images something like a slice of breads, which has been stacked one above to the other. But if you compare it with a CBCT, it's something like a slice of an orange. You have these slices which has been stacked around each other. So you always have an option how to look at it. Yeah, what exactly I mean to say without creating a confusion, like in CT, we try to acquire image going from the foot up till to the head. But that in relation to a CBCT, we try to acquire round the patient. Now, what is the advantage? The amount of exposure is very, very restricted in CBCT. As in relation to a CT, we do not have an option of going for a field of view, like as minimal as 4 by 4 centimeter, which is not an option in relation to a CT. In relation to a CT, most of the time the slices which is being given is in the range of 4 to 5 millimeters. You request for a thinner section They probably go at 1 millimeter sections. That's the cut sections what you get. What exactly I mean? The slices of bread what I spoke is 1 millimeter slices. But that in relation to a CBCT, we usually go in microns. That is 70 microns. That is the least amount of thickness what you get. That you don't get it in a CT. So that's a major advantage. But what exactly happens in relation to a CBCT? We have something called as a concept called as isometric images. Means what? You could have heard about these pixels in relation to a phone. We speak about pixels. What are these pixels? These are picture elements. These are the boxes what we tend to have. This is called as an isometric boxes. Means all the sides, x-axis, y-axis and the z-axis are all the same. So mean to say what? You have magnification which is 1:1. Means to say that there is absolutely no magnification. But that in relation to a CT, the images what we acquire is anisometric. Means what? We don't have a perfect cube. Most of these things are rectangular. Means what? X-axis and y-axis would be equal, but the z-axis, that is the z-axis, the depth would not be proper. So the voxels, the boxes what we get in relation to a CBCT is much more real-time size as in relation to CT, which may not be.
That's wonderful to hear. So in a nutshell, CBCT, you can acquire segmented images, you can pinpoint the area what you look at, thereby minimizing the radiation to other parts of the body, and also much more accurate images ranging even up to 68 or 70 microns, which is not possible in CT. Since we are talking about imaging, some amount of radiation is inevitable, and most of the dentists and even the patients nowadays are concerned about the radiation exposure and safety. So let's talk a couple of points about it. I want to know what is the kind of radiations we are looking in a CBCT as compared to a conventional OPG and a IOPAR and CT.
Like very nicely pointed out, we are going towards digital dentistry. Even the IOPs have been replaced with PSPs as well as with the CMOS sensors. The same with the panoramic radiograph. The amount of exposures what has been given in the literature is all towards the analog films, and most of the studies have happened in relation to Western countries. So if you are using a round collimator with using a normal IOPA radiograph in a clinical setup, it would be say around 4 microsieverts for an IOPA. For a full mouth, it would be around 38 microsieverts, something around, because it again depends in relation to the density of the patient. In case if it is a kid, the amount of exposure as in relation to a healthy patient, it will be different. But when you are trying to compare it with a panoramic OPG, yes, definitely the amount of exposure would be more as in relation to the IOPA. But yes, in relation to the CBCT, it would be more. But in relation to a panoramic radiograph, it would be around something equivalent to the full mouth IOPA radiograph, which is around 30 to 40 microsieverts. But that in relation to a panoramic radiograph, OPG, it would be around again 40 to 60 microsieverts. But that in relation to a CBCT, it is much higher. But this higher grade comes in relation to the FOV what we are choosing about. In case we are going for a lower FOV, the amount of exposure, again it depends upon to the environment, that is the kid, or to a healthy adult. It ranges from 20 to 40 microsieverts. It can also go up till 400 microsieverts. But yes, it requires whether we are going in a high definition mode or to the regular mode.
So it makes sense to go for a device which has got these modes of low resolution, pediatric resolution and high resolution. So we can actually control the amount of radiation depending upon the bone density of the patient, because we believe in the as low as reasonably achievable Allada principle. So thank you for highlighting about that, sir.
Yes, sir. As in relation to the Allada, that was a principle which used to be followed initially. Now also we do follow. Allada is as low as reasonably achievable. But once these digital imaging came, which already almost reduced the amount of exposure to more than 1.5, half to 1/4 of it, the principle changed from Allada to Allada. So what is Allada? Allada is as low as diagnostically achievable. So with the Allada in principle and then the introduction of AI into most of the health component, The machine used to set the exposure parameters by itself. So the concept from Allada came to Allada. Now it is ALA IP. Now what is this? It is protocol associated with the segment what you require. So the amount of radiation can vary, can change in relation to the density of a person, in relation to the tissue density as well as to the bone density.
Oh, that's an eye-opener. Thank you very much for those points. Doctor, since we are speaking on the context of amount of radiation, I would like to know what are the radiation protection devices that we might use, like the conventional thyroid collars or the lead aprons. And the second thing is, can CBCT be used in pregnant women?
Yes, sir. First, I wanted to answer that second question for pregnant ladies. No, definitely no. I wouldn't suggest, whatever may be the reason, definitely no. And coming to the protection, what we say, the conventional textbooks, which what they are talking about, the thyroid collars or to the lead aprons, whichever are there in the market, are basically for the two-dimensional images. In relation to an IOPA, we tend to expose it from the front. So putting a lead apron in relation to the chest area and thyroid collar in relation to the protecting the thyroid becomes essential. But when we are coming to the principle of a panoramic radiograph, where the exposure is basically coming from behind, and we have a receptor which is there in relation to the front, what exactly happens? We are supposed to adapt it by putting the lead apron in the back, as well as the thyroid collar needs to be put in the back. So this is the adaptation what happens in relation to a panoramic radiograph. But that in relation to a CBCT, because exposure is happening around the head of the patient, like it can be 270 degree or 360 degree. So when it is exposure is happening around, I am supposed to adapt my clothing, that is my collar or to my apron on both the sides which needs to be worn. Regarding to the thyroid collar, yeah, it can cause certain amount of artifacts. So the size and shape of the thyroid collar which needs to be used in relation to the panoramic as well as to the CBCT needs to be adapted.
Now suppose a dental clinic plans to invest in a CBCT. What are the requirements that they require in terms of space in their clinic, and what are the requirements in terms of operator or radiation safety that they need to follow in their clinic?
We have certain amount of regulatory bodies in relation to India, what we call as an atomic energy regulatory body, ARB, what we call. Now these people are very stringent about the places where we are going to have a machine, anything which is above 120 kilovoltage potential. So the placement where we are supposed to have. Usually, I have gone to these European as well as to the American countries. Most of the people, they tend to have a panoramic or a CBCT machine in their own setup. So is India nowadays. We have a lot of dentists who wants to install the machine, so which actually helps in their practice. Now, these machines should usually be placed in a place where adjacent to it there should be no man area, so that the amount of exposure should be towards to a no man's area. There would be a slight amount of adaptation which needs to be done to the wall, although the regular wall is fine. Otherwise, you are supposed to go for a 9-inch wall, or you have certain amount of barium paints which can be applied to the wall, which gives a protection. In case if you have an area where you want to have aesthetically appealing, we have certain amount of lead glasses which can be placed around, so that the amount of radiation is not reaching out. And the minimum requirement of a size would be around 6 feet to 6 feet, which is quite sufficient if you want to have just a panoramic as well as CBCT. But if you want a CEF, I think so the component would be a slightly bigger one, so the size of the room would be slightly different. But for a CBCT, yeah, 6 by 6 feet with a regular wall with a barium paint, or you can use lead glass. And it is preferable to have a machine at the end where there is not many number of people who are moving around. So this would be the amount of basic requirements which is essential.
Now that a dentist has decided to go for a CBCT, how can it help the dentist in minimizing the turnaround time or improving the workflow for them in their clinics?
So actually the CBCT actually helps all the dentists in planning it in very appropriate way. And most of the time whenever we are referring a patient to an outsourced center, we usually, the patients who don't turn up much to a greater extent, because their happiness quotient would also be less because they have to go out of the clinic. Now, everything in case if it is there in single place, that also increases the happiness quotient of the patient. So the mental acceptability of a treatment would also be higher as in comparison to whenever you are referring the patient outside. And for the doctor also, so he has the images which are in all sections, which helps him in accurate diagnosis, which shows his confidence towards the patient, which actually helps any patient to accept the line of treatment whenever you're showing it as an educational tool also to the patient, that the three-dimensional things, images what we tend to acquire, that also helps in accepting the line of treatment what the dentist proposes to the patient.
Thank you, sir. So, Dr. Rakesh, you mentioned about the happiness quotient. That's very important for all the dentists who are viewing this. CBCT will not only help you diagnose the challenges that you are facing in imaging, but it will also help in happiness quotient, that is increase the compliance of the patient to undergo the treatment. It will help as an educational and motivational tool to show the defects or the problems or the challenges that the patient is facing. So you can use it as a tool for diagnosis, but which will help in patient education and motivation as well. Dr. Rakesh, everything today is AI based or artificial intelligence based. I am sure it is the same story with the CBCTs also and dental imaging. So where are we in terms of use of AI in reporting in CBCT? Currently, where are we, and what is the future in the immediate future what we are looking at?
Yes, sir. Now, I want to introduce a new concept. It's not a new concept, it's an older concept which is there in relation to the industries. It's called as an Industry 4.0. So, something similar to Industry 4.0, we have something called as an Education 4.0, which actually complied stating that everything can be done automated. So, when I'm trying to compare this artificial intelligence in relation to the diagnosis of the reporting per se, when I tend to go a decade back, it was still in an infancy stage. Now also it is growing. So can I rely totally onto the AI? Yeah, to a major extent, yes, we can as of now, as in comparison to 1 decade old. But there are certain amount of human intervention which is always required. So the same concept comes here from Industry 4.0, Education 4.0. Now we are going for a concept called as Industry 5.0. Now what is this Industry 5.0? With the artificial intelligence, they want to add emotional intelligence. So there are certain times, yes, artificial intelligence, most of the time it is accurate, it is good. But there are certain times which may fail. So in those situations, I would always suggest utilize AI, but with the master. Do not overtly believe in relation to an AI. The concepts like in relation to the industry of Education 5.0, Industry 5.0, where they are trying to tell emotional component is very important in addition to the AI. We have a number of softwares available in the market as of now, which are doing pretty well. The accuracy level is good, but I always prefer a master should always be there behind an AI.
Thank you, sir. So in a nutshell, AI models are becoming more predictable. They are improving over time with as the machine learns, the predictability increases. Right now we have CBCTs which can trace a nerve, which can tell the number of root canals, which can slice the images and give the pathologies, the bone density. However, a word of caution, a trained eye is necessary to operate this AI, and let the dentist be the master and not the other way around.
Yes.
So Dr. Rakesh, you've shared a lot of knowledge with us. So coming to the final questions, would you suggest a dentist today to elevate their practice by going for a CBCT? And what are your views on that?
Patients are becoming much more demanding. So I think so, yes, everyone would probably, I see that in near future, that yes, and I would also suggest that to go for.
We had a wonderful conversation with Dr. Rakesh on CBCT and various aspects of CBCT. To conclude, I would tell CBCT is the future of dentistry in terms of imaging. In the next decade or so, every clinic or every 1 in 2 clinics will incorporate in-house CBCTs. We have given you the requirements, we have given you the safety measures, what is required through our podcast. Artificial intelligence is making rapid strides with many softwares incorporating, identifying pathologies in the images, minimizing your turnaround time, and also helping you educate the patient with the help of artificial intelligence. And we also came to understand that a field of view of about 10 into 10 centimeters is sufficient for day-to-day practice in a dental clinic. Of course, you're a specialist or you're into full mouth trauma cases, probably you require a higher FOV, which you can even attain by altering the patient position in your in-house clinic, or you can refer such patients to a higher center. And we spoke about radiation exposure levels. We will come back with an in-depth podcast again on CBCT, which covers the advanced features available in a CBCT. So I would like to thank Dr. Rakesh for taking his time out and sharing his valuable knowledge with us. So thank you for coming.
Thank you for inviting, sir. That was a pleasure, was also mine. Thank you so much.
So keep tuned in for Confidence podcast. Like and subscribe the issue to get more information about the upcoming podcasts on dentistry. Thank you.